Is me. చెప్పాలమ్మా చంద్ర ఫోన్ చేసి చెప్పాడు నేను మాట్లాడుతూనే ఉన్నాను
చందు ఇంట్రొడ్యూస్ చేయండి మీకోసం వెయిట్ చేస్తున్నాం అన్మ్యూట్ చేసుకోండి
It's not audible. One has to unmute.
Chandu. No. చందు వినిపిస్తలేదు చందు పక్కన ఎవరు లేరా మ్యూట్ అన్మ్యూట్ కన్ఫ్యూజ్ అవుతున్నావేమో నా చందు వినపడట్లేదు వినపడతలేదు చందు No. వినబడతలేదు చందు ఏం చేస్తున్నావు మీరు అన్మ్యూట్ అని ఉంటుంది చూడు మ్యూట్ అన్మ్యూట్ సింబల్ Shall I start, sir?
Yes.
Chandu is unable to connect.
Okay, madam.
Sorry, sir. Dr.Ravi Kumar Reddy, Chairman, Medivision Eye Care Hospital. Sir doesn't need any introduction actually. For the sake of formality, we are doing the procedure today. And sir has done his MBBS from Karnool Medical College, Sri Venkateswara University, Tirupati, and DO from Karnool Medical College, MS Ophthalmology, Karnool Medical College. Has vast teaching experience for more than 40 years of teaching experience and has guided more than 100 PG students to complete their thesis in various topics. Dr. Ravi Kumar Reddy sir is the author of the book Atlas of Ophthalmology, published by JP Brothers, New Delhi, and it was released by the former President of India, Bharat Ratna, late Sri APJ Abdul Kalam, and edited a book called Pearls in Ophthalmology. He has continued his forefathers' legacy in serving the people, both in health aspect and educational aspect. And he worked in famous Sarojini Devi Eye Hospital for about 22 years and held various positions at Sarojini Devi Eye Hospital and Usmania Medical College, worked as associate professor of the ophthalmology and retired as HOD medical superintendent as a professor of ophthalmology. Presently working as CEO and professor in Medivision PG Institute of Ophthalmology. Sir is the founder of Medivision Eye Care Hospital, founder SBVR Charitable Trust, serving education and medical health, Vice President SBVR Group of Educational Institutes. Sir has vast surgical experience, performed more than 1 lakh surgeries, among which 80,000 are cataract surgeries, popularized SICS, PHECO, and the scleral fixated IOLs and DCR. Positions held are Honorary Secretary APSOS for 3 years, editorial member, Journal AP 3 years, and president of AP SOS 2012. He was an academic senate member for NTR University of Government of AP, and he was also a speaker and instructor at Live Surgeries State and National Conference, member of AAO and European Ophthalmology Association APAO, presented many papers in conferences, both national and international conferences. Author of the book Atlas of Ophthalmology, published by JP Brothers, New Delhi. Editor, Clinical Pulse in Ophthalmology. He is very much interested in community work and conducted thousands of eye camps in rural and backward areas to provide all kinds of ophthalmic care for poor and underprivileged. He was inspired by the government's national program for control of blindness, NPCB, formed a charitable trust, SBVRM, in the year 2000. And the mission of the trust is to provide eye care to the poor and needy at free of cost. So far, he has performed more than 20,000 free surgeries and also provided glasses to the needy at free of cost. Thank you, sir. Over to you.
Thank you, madam. I am lucky to have this meeting, and I may not be that much you praised because I always say we are sitting in the air condition and doing job, whereas you people are in the rural places. The working conditions are very much difficult, and still you are performing a great job. I always feel that you are greater than me. The topic given today is cataract. So this cataract, normally we call it as an undergraduate topic. So, but it is, I want to enlighten some of the areas to stress and give the utmost care, because the commonest operation performed on human body is cataract. So that also we have two eyes, that is 2x. So two times the patient visits the ophthalmologist, and that's why this becomes a commonest surgery on human body. The other thing is, as you know, the vision is most important for all the people, whether it is educated, non-educated. The burden of the blindness is not only on the person, the entire family and the society when one person becomes blind. So that's why the vision is most important, and the commonest surgery performed is cataract. And the second commonest disease here is the glaucoma, which my colleague Dr. Meena is going to enlighten. So coming to the cataract, what is cataract? So the cataract is the clouding of the crystalline lens is called as cataract. The crystalline lens becomes cloudy uniformly in all aged persons. Say, for example, if you take a people above 60, some amount of opacity in the lens will be there, which may be visually significant or visually insignificant. When it is visually significant only, we advise them to undergo surgery. When there is visually insignificant, we will ask that particular patient to wait for some more time. The other reason why the cataract is common to all the people means this is the structure which is going throughout the life of the human being. Say, for example, the height of the person will go to some extent like 5.8, 5.6, like that, it stops. Whereas the human lens going on increasing in size as the new lens fibers are added from the equator of the lens. So that's why when you see in the early stages, the anterior chamber is deep. As you observe, the anterior chamber becomes shallow, and results in angle closure glaucoma. So there is a chance of glaucoma in mature and hypermature cataract patients. That's why there is the need to identify the early stages of the cataract and intervene when there is a visually significant cataract. So this is the human eye. where the lens is in the area shown in the figure, whereas the anterior portion of the lens is covered with the subcapsular epithelium, which is active at the equator. So, from the equator, the new lens fibers are going on producing till the death of the patient. So that's why the size of the lens grows, the central fibers gets compressed. When the central lens fibers are compressed, we call it as a nuclear cataract. So that's why as the age advances, it is uniformly we experience physiologically a nuclear cataract for all patients, resulting in a minus power. This minus power causes difficulty for distant vision in older people. So this is one type of cataract which is physiological for the age. Then the other etiological factors is, as I told you, age is the commonest factor. Second is the hormonal imbalance, especially the diabetes and the thyroid. They think that you do see the cataracts as in young as a newborn, which we call it as a congenital cataract due to congenital anomalies or the maternal malnutrition or maternal infections. The trauma, direct injury or indirect injury to the lens causes dramatic cataract. The inflammations in the eye is called as uveitis, also results in cataract, which we call it as complicated cataract. The radiation for any reason patient is exposed, it also results in cataract. There are so many other factors which induces the cataracts, especially the drugs called the steroids. So the symptoms of the cataract is there is no pain. There is no pain in the cataract patients, but the symptoms are blurring of the vision. The distant vision gets blurred, and even small letters are blurred. Then there is a glare phenomena, halos, the diplopia, polyopia, like that. The main symptom is the diminution of vision. So the types of cataracts, as I told you, the nuclear cataract is due to compression of the central fibers, which will appear as a brown cataract or a gray, the black cataract. So this is induces a myopia where the patient says, "I'm not able to see the distance, but I'm comfortable with my near vision." The other cataract is called as a cortical cataract, where you see a spokes of opacities all around the lens and the center is clear, and the patient generally complains of the night blindness, and sometimes even the day gets obscured. The other common cataract is called as posterior subcapsular cataract, where the cataract is limited to the posterior portion of the lens. The other funny cataract is called as a posterior polar cataract. Why it is funny is it occurs as young as 20 years of the age. So the 20 years patient comes with blurring of vision, not able to tolerate the light, not able to drive in the nights. You see a central disc-shaped opacity, which we call it as a polar cataract, which is difficult for the patient, which is also difficult for the operating surgeon. So then, what happens when you wait unattended cataract, especially in the rural areas where the ophthalmic care is not available or sparely available? So they go into a condition called as angle closure glaucoma. As I told you, there is a bulging of the lens, swelling of the lens, and results in glaucoma. Or even over maturity results in subluxation and dislocation, where the lens will disappear into the anterior chamber or into the vitreous cavity and causes glaucoma and uveitis. The other thing is the lens protein becomes liquefied. The liquefied cortex will leak into the eye and results in phacoanaphylactic uveitis. So as I told you, the glaucoma may be a phacomorphic glaucoma or phacolytic glaucoma. Morphic glaucoma is due to size of the lens. A lytic glaucoma is due to the leakage of the lens protein. So there is an inflammation called a granulomatous reaction, and your patient will experience redness, pain, and watering, all due to negligence, unattended patients. Funnily, surprisingly, today I have seen one patient who is working as a police officer. So there is a lens-induced glaucoma, a pressure of 50s. So why I asked why you didn't attend in a proper time, where is residing in the city means I have my own work, I'm busy with my work. The moment I experience pain, I am attending you. So that is called as a phacomorphic glaucoma with high pressure, which is again results in a poor prognosis even though we operate on these patients. Then the subluxation and dislocation, still if you wait for some more time, the zonule is the suspensory ligament between the lens and the ciliary body. The zonule becomes weak and it will give away and results in either subluxation or dislocation, where we have to resort some other fashion of the surgery than the routine cataract surgery. So, for a pre-operative evaluation of these cataract patients, previously we used to do camps. In my lifetime, one day we screened 10,000 patients in a rural place. The other thing is one day, along with our team, with my professor at Karnool, we went to Dharmavaram in Anantapur district. We operated 575 cases in one day. So these were the situation those days where it's not possible to examine in detail. The examination those days was torchlight. This is 40 years ago. Torchlight examination, giving a red paper to one patient, white paper to one patient. White paper means you can go home. Red paper means you stay there. Then we used to operate with a knife, and the entire surgery is completed in 2 to 3 minutes. So like that, we operated 500 and odd patients in a day. In a what that is called as market yard. So, like that is the situation those days where the eye care professionals are very less and the patients are waiting, and the cataracts are white cataracts, mature and over mature. Nowadays, fortunately, a lot of advancement is there. A lot many our eye doctors are there doing a wonderful job and doing examination in detail. Take me from me, there are two things for the success of an eye surgeon. One is thorough systematic examination of the eye. So a thorough systematic examination will give, as you see in a mathematics, you do step by step what is called as working. If you do working properly, and you get an answer automatically. So if you do haphazard working, you get a wrong answer. So that's why if you put a garbage in, you get a garbage out. So like that, systematically you examine the eye, you will find not only the cataract. Along with the cataract, patient is suffering with glaucoma. Along with the cataract, patient is suffering with the diabetic retinopathy. Along with cataract, he is having a corneal problem. Along with the cataract, he is having inflammatory problem. All these will be known if you if you spend some time with the patient, examine step by step. After that, only you will attempt. Haphazardly, if you do it, you may land in problems, and afterwards the litigations with the patients. That is one thing. Second thing is the thing is spend some time with the patient. You explain the situation, then pros and cons. These are the benefits. These are the risks after your cataract surgery. So if you follow this, the yield is good. or your eye is not up to the mark, your eye is bad, even then you may not get the expected vision. So all these communication, if you communicate properly, if you investigate properly, if we examine properly, there won't be any problem in post-operatively with the patients. Nowadays, the litigations are more, and more than the patients, attendants, the other fellows who are having no job, they are always instigating the patient and troubling the physician. So the examination is by magnification, not by torch, not by loop. You have to use the microscope. This microscope is called as slit lamp by microscope. That slit lamp microscope should also be very good in condition. Now and then it requires some servicing, and you see that your slit lamp is up to the mark. Next thing is the majority of the cataract surgeons ignore the posterior segment. So the posterior segment is the segment behind the lens. The behind the lens is vitreous, retina, choroid, sclera. So if you ignore the posterior segment, the yield is less because the heart of the vision is the retina. In that heart, retina, the two important structures are optic nerve and the macula. If the macula and optic nerve are healthy, you can promise the patient. If the macula and optic nerve are in doubtful position or unhealthy, don't promise the vision to the patient. So if you examine the posterior segment, then only you can promise the patient. If you are unable to examine, if you are not having this proper equipment to examine the posterior segment, don't promise the patient. So this is how we evaluate the fundus. So the indirect ophthalmoscopy gives a thorough peripheral as well as the central part of the eye, whereas a direct ophthalmoscope give only the posterior central portion, but the peripheral lesions you may miss it. Another advantage of the indirect ophthalmoscopy is the light source is 12 volts, whereas with your slit lamp and the ophthalmoscope, the light source is 3 to 4 volts. So the strong illumination will penetrate even with the dense cataract. Even with the dense cataract, you can evaluate the macula and the disc. Whereas the other fundus evaluation 90D gives a detailed structure of the macula and the surrounding structures, where you can say this patient will get 6.6, this patient will get 6.9, like that by your experience. So both are important. Magnified view as well as the peripheral view is important to assess the posterior segment. So to determine the IOL power also important. You are a very good surgeon, but
Okay.
Okay, sir.
hello, yes, hello, anything? Am I audible, madam? Am I audible?
Yes, yes, sir.
Yeah.
You go on.
Somebody. So the pre-operative investigations for cataract surgery are also important. We used to do only 4 investigations when we were postgraduate. What are those 4 investigations? Means blood pressure, blood sugar, lacrimal test, intraocular pressure, then do the surgery. So those are the basic tests we used to do in the camps and even in the medical college. Now we have so many gadgets, for each instrument have its own meaning. Say for example, A scan is useful for a dense cataract. What we do is ultrasound biometry. The AL scan in the IOL master is gives a comprehensive idea of the corneal curvature, corneal power, next lens, next is the axial length, even it delineates the foveal architecture. So this is having a lot of advantages called with IOL Master 700. When there is a dense white cataract, you are not able to see the posterior segment. You have to use a ultrasound B scan to know the intactness of the RCS complex. RCS means retina, choroid, and the scleral complex. So then only you will have some idea about the integrity of the posterior segment. So this is how we use the A-scan IOL master. When you get clear readings with IOL master, you need not depend on the A-scan. When IOL master is in doubt only, you go for A-scan. Next, the B scan, when you are not able to assess the posterior segment with the indirect ophthalmoscope or slit lamp biomicroscopy, we use the B scan. And the AL scan will give some additional information than that of A scan. Then the corneal thing, the integrity, curvature, you will be knowing with the pentacam or the topographers. Even the IOL master also gives some idea about the corneal curvature. Then the corneal endothelium. This is most important. Why means if the endothelial count is not up to the mark, the endothelium is unhealthy. If you do phaco surgery or your small incision surgery, patient will develop post-operative corneal edema, bullous keratopathy. He will simply claim that it is due to your surgery. I got this corneal problem. Or your own colleague will comment, the proper surgery has not been done. That's why you developed this bad. You don't know, or the other colleague don't know whether his endothelium is up to the mark or not, unless you do the specular microscopy. So, as a routine in cataract surgery, I advise to do the specular microscopy for all the patients, which will take 1 extra minute to do this scan. So the other important thing is the OCT. OCT gives the layer by layer anatomy of the retina. So especially as I told you, the disc and the macula are important to get 100% vision or 6/6 vision. So I recommend the OCT for all cataract patients, where you can promise the patient the post-operative, you may get normal vision or abnormal vision. You believe me or not, in our institute, as a routine, we do the OCT. 3 to 4 patients every day, 3 to 4 patients, we pick up some macular pathology and refer these patients to the retina before cataract surgery. So we see ARM, ER means epiretinal membranes, we see macular holes, we see macular edema, especially in diabetic patients. We see some amount of abnormality in the ganglion cell layer. So thinning of the ganglion cells, where patient is asymptomatic. He says, I have no problem, I have no BP, no sugar, all this. But if you do OCT, we see the thinning of the ganglion cells, where the outcome, the contrast for these patients will be less. And these are people are not at all suitable for premium lenses like multifocals and extended depth lenses, where they spend a lot of money and becomes unhappy after the surgery. So then routinely you have to see the blood pressure, blood sugar, viral screening. There are some surgeons, don't worry about the sugar. We are making a very small 2 incision, it will heal. It is not the incision, it is not the healing. It is the inflammation. When there is a blood sugar is high in the body, the inflammatory markers will be high, and you get a post-operatively uneventful reaction and a macular edema. So macular edema is more common when the sugar is not under control. So similarly, BP patient on the table, some problems will occur, especially expulsive hemorrhages. So to avoid the contamination, we do the viral screening routinely. So the types of surgery, coming to the treatment, types of surgery, ophthalmic friends, you know everything. But for the sake of the general physicians, we'll show some videos. Commonly now what we are doing is the small incision cataract surgery, then the phaco surgery, then the femto laser assisted cataract surgery, when the jonule is weak, as I told, dislocation and subluxations, there is a procedure called scleral fixated surgery, which is also not uncommon. In my institute, every day, one or two scleral fixation surgeries are done because patients do come in late stages. Our own friends are referring to me for scleral fixated IOL. So this is how the setup is. The setup also is very important to avoid the dreaded complication called endophthalmitis. So endophthalmitis is in fact post-operative infection into the eye. So the environment should be clean. Where in my theater there is a laminar flow where the air is filtered, the size of the filter is 3.3 microns, where the virus also get filtered and you get a excellent atmosphere. On the right side, the high-end equipment called as femto laser, which costed us 5 crores in 2016. This is the video showing a small incision cataract surgery where I recorded this in Sarojini Devi Eye Hospital as early as in 1999. That means in 5 years ago. So that is a sclerocorneal tunnel, a side entry. Then we make a opening in the anterior capsule, which we call it as anterior capsulorhexis. So then we inject the fluid into the lens substance, dividing the lens into nucleus and the epinucleus and the cortex, so that the size of the lens becomes smaller and smaller. This smaller nucleus is expressed by viscopressure. We inject methyl cellulose into the eye, and this methyl cellulose will depressed the posterior lip of the sclera, and the nucleus is extracted by visco expression. There are so many methods of delivering the nucleus. Even you use an instrument called vectis or some other methods, which I may not be able to show all in this short time. So this method is called as visco expression and a cleaning of this cortex, polishing of the capsule. Then we'll introduce a lens called PMMA lens. So this is non-foldable lens, which is much economical, especially suitable for poor patients and charitable institutes. Even now, it is suitable. This small incision surgery. Many people are practicing in the rural setup and charitable institutes. This second surgery is called as phacoemulsification, where we have the ultrasound is sent to the nucleus, where it is made into number of fragments. These small fragments are aspirated through the probe. So this is how we do the anterior capsulotomy, called as circular rhexis, CCC. Circular rhexis, we make it and we hydrate the thing. We call it as hydrodissection. Then rotate the nucleus. This is emulsified using a ultrasound tip. This is how the ultrasound acts. So manually with the left hand, we are making into small fragments, which we call it as chopping. So we chop the nucleus into small pieces. The small pieces are emulsified by means of ultrasound. Then the cortex is thoroughly cleaned. Because the incision is small, we have to always use a foldable lens. So there in small incision we use a rigid lens. This is a foldable lens which goes into 2 mm or 2.2 mm or at the maximum 2.8 mm. So the healing is quick and the patient comfort is better than that of a small incision surgery. Coming to the latest surgery called femtocataract surgery. This is where we use a femto laser. Before applying the laser, we have to apply a cup to the patient. So, what we call it as PI. PI means patient's interface. Patient's interface means I to the mission, we apply a interface which is having a cup and the magnifying lens. So after coupling, the mission will do the OCT. OCT means online OCT. What you are seeing is the anterior cornea, the lens. Then, depending on the thickness of the lens, it will fire. So it fire into number of fragments, predetermined fragments. So if you want 200 microns, it will give 200 microns. If you want 100 microns, it gives 100 microns. Here we are using 200 micron chops, and already the capsulotomy and the fragmentation is over. Your job is simply aspirating those material and afterwards cleaning and implanting the lens. There is one more method, as I told you, when the zonule is weak, we have to use the special lens called, in which we make three openings in the conjunctiva. The superior is called the main incision, the side is called side incisions, like this. Yes. We have to use the sutures. This suture is called as prolene, which is non-absorbable. The size is generally 90 or 10 prolene, which is the finest thing. So this prolene is passed from one entry to the side and cut into two pieces. Each piece is sutured to the ends of a special lens called scleral fixated lens. This scleral fixated lens is fixed to the sclera, no need of any capsular support. So this is how we see in a live thing. Next. So this is a case of a subluxated traumatic cataract. A young person came with trauma. The lens is subluxated, where the routine phaco surgery or small incision surgery is not possible because the zonule is lost. Here we make a opening similar to that of a small incision surgery. So this is the prolene suture with a long needle. So that is passed into a 26 gauge needle, what we call it as a railroad technique. Now the incision is enlarged as large as 6 mm. The liquid what we are injecting is known as hyaluronate or helon. So here the sodium hyaluronate is injected, which is compatible with that of the vitreous. Slowly inject, pressurize the globe until the nucleus delivers. So this is removed uh, except the small amount of the cortex, which also became. This suture to the scleral fixator lens, both ends, and introduced into the posterior segment. So then you suture to the sclera. This suture is a permanent and non-absorbable. If any vitreous is there, you can do vitrectomy at the end of the surgery. Coming to the type of lenses, what we implant is called as a monofocal lens, multifocal lens, toric lenses are available with us. The monofocal lens gives a crisp vision, but they correct only the distant vision. The patient has to use the glasses for intermediate and near vision. There are lenses called hydrophobic lenses, hydrophilic, depending on the material. What we prefer to use is hydrophobic lenses. Why means hydrophobic lens will cause less amount of posterior capsular opacification, blurring of the vision after the cataract surgery is less. Whereas hydrophilic lens attracts the capsular opacification, and second intervention is necessary in majority of the hydrophilic lenses. So then the recent advances in the intraocular lens is extended depth of focus lenses, where you give a range of vision, a distance to intermediate, and even to some extent the near vision. Then the multifocal lenses will give both the distance, intermediate, and near vision. Only the disadvantage is the glare and halos are there, especially in the night, and that's why we don't advise them for the night driving drivers. So there is a lens called toric lens, which is having the capacity to correct the cylindrical power. We call it as astigmatic correcting lenses. They are available in monofocal range, multifocal range, EDOF range. So the complications of cataract surgery, why patients gets delayed to attend means they are afraid of the complications. So these some of the complication is posterior capsular opacification, nowadays very rare. Posterior capsular rent during surgery where we may not be able to place the lens on the table. Then they may get the retinal detachment, corneal problems, or post-operative infection. As I told you, the dreaded complication is called as endophthalmitis or post-operative inflammation, red eye even after surgery, completion of the post-operative period, recurrent inflammation and problem to the patient. So then the IOL itself may displace called subluxation or dislocations we are encountering, where implanted 20 years ago, 30 years ago, implanted, now they are coming with the subluxation and dislocations. Some of the IOLs, especially in 2023, last year, we have seen 6 cases of IOL opacification referred from Nalgonda district. So this is due to the quality of the IOLs. The IOL become white, and we have to remove these IOLs and replace with another IOL. This is the one example where you see opacification of the IOL, and we removed it and implanted another lens. This is how the posterior capsular opacification, where the patient again says, "Doctor, your surgery is failed." Previously, I used to see now as that of the cataract, there is a blurring of the vision. I am not able to see. For which we do a small procedure called ag laser capsulotomy, which takes only 2 to 3 minutes. Again, patient regains the vision. This is called as a dislocated IOL, where the air we remove this IOL, we do the scleral fixated lens for this type of patients. The take home message is before treating, can you prevent cataract? These are the questions by the some of the patients. There are generally no medical treatment, no prevention we sell, but still there are some tips to delay the onset of the cataracts as you see, I have seen twin brothers. One brother is doctor, another brother is a engineer. The engineer developed cataract first. The doctor not yet developed. Even now, he has not developed the cataract. Where we say that because of the exposure to ultraviolet rays, the engineer developed the cataract. The doctor has not yet developed. So then the balanced diet, we do see the rural people get that earlier cataract with malnutrition than that of urban people with well nourished. The antenatal care, the anemic mothers, rubella infections, vitamin D deficiency, these patients will deliver the congenital cataract patients. So the good control of diabetes delays the cataract and the thyroid. So avoid the cataractogenic drugs, stop smoking, avoid injuries to the eye, and regular eye checkups. The early surgery gives the better results. Sorry for taking more time. Thanks for giving the opportunity. I am ready to answer any questions, or after the glaucoma talk, I'll be waiting for your questions. Thank you, madam.
Thank you, sir. Dr. Chandu is available, sir.
Hello.
Dr.
Hello.
Chandu.
Good evening, madam.
Yeah.
Hello.
Sir, good sir.
Good evening.
Good evening, sir. Sir, what is the advantage of iris claw lens over the scleral fixated lens?
What is the disadvantage or advantage?
Oh, yes, sir.
Advantage is easy to do, and the time is less time. Disadvantage is it releases the pigment throughout the life. The other thing is you cannot visualize the posterior segment properly when there is a retinal problem. Third thing is I have seen the displaced, the scleral fixated, iris fixated lenses, so many where we explanted and did scleral fixation. They said it is excellent, but I have seen so many cases landing in the vitreous after their surgery.
Sir. So, what is the advantage of femtosecond cataract surgery or capsulotomy?
Oh, as far as the capsulotomy is concerned, one thing is when there is a intumescent cataract, the moment you start the capsulotomy, normally it goes into Argentinian flag sign. Once you lose the capsule, no phaco. Whereas in femto, 100% you get the rexis. Then you get a central rexis. You don't know whether you are doing centrally or eccentrically. You get a round rexis. You get a correct size rexis. Somebody is doing one step for you. This femto is somebody is doing one step for you where you can enjoy that. Say for example, if you want to do a 5 mm rexis, central rexis, circular rexis, thousands of surgeries are required to become master. Whereas a beginner can do with femto help a central 5 mm rexis. Say for example, I am very much impressed in two areas. One is intumescent cataract with the liquid in the lens. The other is pediatric cataract. Pediatric cataract is not yet given license even now. Even then, I recommend your child to go a femtorexis. Femtorexis. Why means that is the key step to stay the IOL throughout the life in that child. If you lose the rexis, you cannot implant the lens in the bag. The lens will come out. It will cause all the problems, pupillary capture, corneal decompensation, all the problems. So that bag implantation, correct place implantation is possible if you do the rexis properly. The other thing is in the rexis, normal rexis, any phacosurgeon will aim for the pupil center. When the pupil, you take the reference of the iris margin as a reference. That means you are doing your rexis as a pupil center. Whereas femto will scan the entire capsule, entire size of the lens. It makes the capsule center, not the pupil center. If you take in some of the patients, the pupil is eccentrically placed, especially to the nasal side, or sometimes dilatation itself is eccentric. One side more dilatation, other side less dilatation. Whereas the femto will give the centration of the capsular bag rather than the pupil. Yes?
Okay. One more question, sir. If Rexis goes for periphery, can we continue for phaco, sir?
Yeah, if it is a continuous CCC, continuous curvilinear rexis. If it not a linear also, if it should be continuous. If it is any rent or the given away, definitely it will reach to the posterior, isn't it? But in the hands of the experienced surgeon, even the rexis is lost, you can do it, especially when it is N1, N2, at the maximum N3, not N4. That means hard cataracts don't do that. Because in hard cataract, you do more ultrasound, more time, and there is every chance of yielding the posterior capsule. Whereas if it is a soft cataract, you can even deliver that cataract to the AC and do the AC emulsification with low energy where you won't damage the endothelium. So in a soft cataract, even you lose the anterior capsule, you can do it. In hard cataract, don't try that. Whereas if it is a continuous and extending beyond your pupil, you can do it. Nothing wrong.
Okay, sir.
Yes.
Thank
you.
Anyone having questions?
We'll have question and answers in the end, Dr. Chandu. Now we'll move on to the second topic. I now invite Dr. Kumar Rao, civil surgeon ophthalmologist from Government Hospital Nalgonda, to chair the second session and to introduce the second speaker, Dr. Meena Madam. Over to you, Dr. Kumar Rao.
Thank you, madam. It's my pleasure to introduce Dr. Meena Thotakura. She is a consultant glaucoma department at Medivision Eye Care Center, Mehedipatnam. She completed her MBBS from Dr. NTR University of Health Sciences, Kamini Institute of Health Sciences, and her diploma from Manipal University, Karnataka, Kasturba Medical College, Manipal. And she's a fellow in glaucoma and phaco emulsification in 2020 from M.M. Joshi Eye Institute, Hubli. She got awarded for the gold medal from Kasturba Medical College, Manipal in ophthalmology and the best video for the resident wet lab training with the Vegan Wet Lab during AIOC 2021. She presented 4 posters in national conference and 1 paper presentation. She published 2 publications. One is endogenous endophthalmitis in patients with MRCS septicemia. The second one is macular horseshoe-shaped tear following cricket injury. So now I'll introduce over to Dr. Meena. Please start your topic, madam.
Thank you, sir, for the wonderful introduction, and thank you, IMA Telangana branch, for this opportunity. It is a little difficult to follow Ravi sir as a speaker, but I will try to do my best in conveying my message across, that is raising awareness for glaucoma. Glaucoma is, we call it the silent sight thief, because the patient is not aware of glaucoma until the final stage is reached. Why it is so, we'll discuss in the subsequent slides. Why is it important that we identify it early and treat it aggressively? Because once the vision is lost, it doesn't come back. So a brief introduction about glaucoma. It is a group of diseases characterized by progressive optic neuropathy or disc damage. We can see the progressive disc damage that is occurring here. This is a normal looking optic disc or the optic nerve head that we call, with a normal cup to disc ratio. This is a moderately damaged disc because of glaucoma. We can see that the cup is increasing in size with the vessels moving peripherally, with damage of the nerve fiber layers in that area. This is an advanced glaucomatous damage in which the entire neuroretinal rim or the entire nerve fiber layers are lost because of glaucomatous damage. So there will be corresponding visual field defects in this type of glaucoma, and increased intraocular pressure is one of the major risk factors for glaucoma. It is the second most common cause of blindness worldwide. Cataract is the first most common cause, but unlike cataract, in which the patient will immediately tell that he has a blurring of vision, glaucoma will not have any symptoms until the end. And even unlike cataract, which is reversible with the variety of cataract surgery options that sir has explained so well, glaucoma is irreversible. The damage that has already happened will never come back. And in India or anywhere in the world, it is largely underdiagnosed. Approximately about 120 crore people in India, that is 12.8% of our population, carries the burden of glaucoma. And as I said, it is severely underdiagnosed condition. This table shows the age-wise prevalence of glaucoma. It is as low as 0.4% in the early 30s to 40s, and subsequently it is increasing to as much as the higher limit being 6. That means above 80, the risk of glaucoma is every 6 people in 100 people may have glaucoma. So we need to start screening for glaucoma, especially in the elderly. So the prevalence is doubling almost in 1 decade from the 60s to the 80s. So why is it difficult to diagnose glaucoma? What are the challenges that we face? Majorly, the first thing is that it is asymptomatic till final stages. What I usually explain to the patients is that it's as if you're removing a small grain of rice from a whole entire rice bag, 1 grain of rice every single day. You will not even realize that some problem is happening until the very end, until the almost half the bag of rice has gone. We will not realize that something is going wrong when we do it 1 single point every single day. The same thing with glaucoma, because only 0.001% of the nerve fiber layer damage occurs every day or over a period of time. The patients don't realize that something is wrong until the very end. We can see the visual loss being progressively getting lower and lower, becoming constricted as the disease progresses. This from here to the end stage, this progression might take easily over 4 years or 5 years also. That is why the patient does not realize. Secondly, as much as we try to advocate, routine eye checkups are not yet standard practice among our general population. Even though we have blurred vision, we go to our optometrist, we go to an optical shop, we just get our vision checked, take a spectacle, and we think that our eye examination is complete. It is by no way complete, and it is very, very important that we visit an ophthalmologist to get our intraocular pressure checked and to get our retina screened for retinopathy. Our optometrists are improving now in that they are able to see the disc and comment on glaucoma, but still, unlike the Western civilization, our optometrists are not yet qualified or educated enough to detect glaucoma as a on a screening basis. And even among the patients know about cataract. Patients now, they are getting to know about diabetic retinopathy. But glaucoma still is a long way to go in getting the awareness of patients, because even when I try to explain to patients, this is how your eye is, this is what the condition is, they don't understand, or they think that we are just exaggerating the condition and telling. So when glaucoma becomes as popular, I should say, not in a right way, but still when it becomes as popular as diabetes, hypertension, or cancer also, we have a chance of combating glaucoma only then. Before going to the symptoms or what to expect in glaucoma, there are 2 major types of glaucoma, the open angle and the closed angle. Going back to our basics, the aqueous humor, that is the fluid in the eye that is produced from the ciliary processes here, it circulates to the posterior chamber. goes through the pupil into the anterior chamber and drains into the angle. In closed angle, what happens is the lens iris diaphragm is either pushed forward or pulled forward by various mechanisms, which results in angle narrowing. The aqueous is thus unable to reach the trabecular meshwork from where it drains. So this is closed angle. However, in open angle, the aqueous reaches the trabecular meshwork, but because of the resistance offered within the trabecular meshwork itself, because of various reasons, the fluid is unable to drain, which increases the intraocular pressure. So with this in mind, let's go to the major complaints which the patient might have. This is again very, very rare that a patient comes to us with complaints of glaucoma. It is mostly 99% of the time an incidental finding. Take for instance, today in our OPD, we would have seen around 40 patients in our glaucoma clinic, but major ones are still referred from other departments as a disc suspect or an IOP suspect, but not see patients who themselves come for glaucoma screening. So very, very rarely, very perceptive patients may complain of a diminishing visual field. Somewhere in the periphery, they feel that the visual field is reducing or some blurring is there. Some patients may have bilateral brow ache or heaviness over the eyes, and in advanced stages, even then the patient will not complain of a field defect. He will just say he has blurring of vision. Closed angle is a little more easier to catch because the patient becomes symptomatic. In the initial stages, because of acute increase in the intraocular pressure, the corneal edema develops, because of which when the patient looks at light, he sees a rainbow of colors, that is colored halos surrounding light. And this is the picture of an acute attack of angle closure glaucoma. You can see the angry red eye with a dilated pupil, a very shallow anterior chamber which can be detected by a torch also, and corneal edema which will be present. The cornea will be hazy to look at on the torchlight. Glaucoma is an angle closure glaucoma is an ophthalmic emergency. Hypermetropes, because they have a smaller eye configuration, they might develop angle closure attacks, especially when the attack happens is when they are reading in dim illumination, or when they are watching a movie in a dimly illuminated space. They might develop this attack, or when they go for an eye examination, if the eye is dilated, because we missed the shallow angle also, patient might develop an angle closure. Diabetics and hypertensives may develop angle closure because of the neovascularization which occurs. Uveitic glaucomas also can result in angle closure because of the synechiae that are formed around the angle. There is 360 degrees blockage of the aqueous flow, and so the angle closure may occur. And sir has already explained in detail how the lens induced causes an angle closure attack. Post-traumatic, it causes a bleed into the anterior chamber, what we call hyphema, that can cause an angle closure attack, or an acute spike in elevation, which may cause a high IOP. So what are the risk factors for glaucoma? Whom should we suspect and screen for glaucoma earlier? Patients with a higher intraocular pressure are at risk. Obviously, this is the most important risk factor for glaucoma, that is high intraocular pressure. Increasing age of the patient, as we have seen in the prevalence, the prevalence for glaucoma is almost doubling towards the 80s. So in elderly especially, we have to screen for glaucoma very diligently, especially in our peripheries. Then a positive family history, especially in the first degree relative, is very, very important for glaucoma. There is a 5% chance that there is a presence of glaucoma in a first degree relative. Refractive errors, myopia predisposes to an open angle glaucoma, and hypermetropia for a closed angle type of glaucoma. Diabetes mellitus, as I have told before, predisposes to a neovascular glaucoma. Vascular factors like migraine, Raynaud's phenomena are not very common, but still risk factors for glaucoma. This I want to emphasize very, very, very highly, because steroid use, any form of steroid use, let it be a topical ointment for a skin allergy, let it be an inhaler or nasal drops which we are giving for asthma or any form of allergic rhinitis, or oral steroids which we might give for autoimmune diseases, which we give following transplantation. All these, any form of steroid can cause an increase in IOP, and the increase in IOP goes unnoticed. The steroid gets being used by the patient, and the patient often comes to us with end stage glaucoma, in which stage we are helpless. Eye trauma, not only the acute eye trauma which causes hyphema, history of eye trauma more than 10 or 20 years back also is significant, because at that point of trauma, there could have been a damage to the trabecular meshwork, which manifests as glaucoma later on in life. We call this angle recession glaucoma. Sleep apnea is becoming a very, very important factor in glaucoma, because even though we are maintaining the intraocular pressures within the normal range or even lower than the normal range or target as we call it, glaucoma is found to be progressing, because sleep apnea is increasing in the population and it is causing a progression in spite of a well-controlled eye pressure. We have found that as the sleep apnea we are controlling with BiPAP or CPAPs, the glaucoma progression is also getting halted then. So when the patient comes to us with all these, we make the diagnosis of glaucoma based on a raised intraocular pressure, structural damage to the optic nerve that I have depicted in our first slide, and loss of visual field, which we do based on a Humphrey visual field test. All these three might not be necessary for diagnosis of glaucoma. Only a raised IOP without any damage to the optic nerve or visual field we call ocular hypertension, which we have to observe very closely. And there can be damage to the optic nerve and field in spite of a normal IOP. We treat that as a normal tension glaucoma. Whom should we screen for glaucoma? Usually we tell you have to get yourself screened routinely, yearly once, everyone over the age of 40 years. But maybe in people who have a positive family history, even at a younger age, more than 30, it is better to screen. In juvenile variants from 14 or even 10 years of age, it is better to screen those people who have a family history of juvenile variant of glaucoma. Patients who are high myopes and hypermetropes should get themselves screened regularly, yearly once, on any form of steroids until the steroid therapy is stopped. And even 6 months later of stopping the steroid therapy, we need to keep checking for any intraocular pressure spikes. And history of eye trauma is important. Please consider this. What are the treatment options available to us? The first line, we always start the patient on topical anti-glaucoma medications, that is eye drops. The groups of drugs available to us are prostaglandin analogs like latanoprost, bimetoprost. Beta blockers, the most common that we use is timolol. Carbonic anhydrase inhibitors, we use dorzolamide, brinzolamide. We do give oral acetazolamide, that is Diamox tablet, for patients who have acute spikes of IOP. And alpha agonist brimonidine we use for treatment. Coming to the lasers part, we have a variety of lasers that we do for glaucoma, like laser iridotomies, laser trabeculoplasties, iridoplasties. But I will show a small video of the iridotomy that we commonly do in our outpatient department. So in an angle closure attack, what is happening is the angle is unavailable. So what we do is we make through a laser, Nd:YAG laser or an argon laser, we make a small opening in the peripheral iris, which provides an alternate pathway for the aqueous to flow into the trabecular meshwork. Thus, this removes the angle closure component. So this is about lasers. Then coming to the surgical part, we have a huge armamentarium. Like cataract surgeries, we have a huge armamentarium of glaucoma surgeries available to us now. Trabeculectomies, shunts like Ahmed valves and Barveld valves. Now the latest is minimally invasive glaucoma surgeries, which we are doing along with the cataract surgery. We use a small stent and place it into the trabecular meshwork so that there is increased drainage of the aqueous through the damaged trabecular meshwork. Then we have procedures like trabectomies, goniotomies, in which we incise a portion of the trabecular meshwork. However, trabeculectomy surgery is still the gold standard.
Doing trabeculectomy
I'll show
surgery.
you a small
Drop the
video
ball, just
about
makes
this
it-
surgery, animated video. See, we open the conjunctiva, then from either the fornix or the limbus. Then after that, we make a partial thickness scleral flap, which is attached at the limbus. Then through underneath this flap, we cut a portion of the peripheral cornea and the trabecular meshwork. So through this, we are again providing an alternate route for the aqueous to flow out. After we suture back the conjunctiva, the aqueous collects in the subconjunctival area in the form of a bleb. So because of the resistance provided by limited space and resistance provided by the conjunctiva, the fluid does not overtly drain and the enough amount of aqueous comes out so that the bleb gets filled. So this is something like a controlled fistula that we are making. So coming towards the end, what messages I would like for your clinics, please help us in combating glaucoma, recognize the symptoms of angle closure. And most of these patients, I have seen patients being referred from our physicians, surgeons, because they present to them with nausea, vomiting, headaches. So whenever a patient is holding his hand over the eye with headache, please shine a torch into the eyes and see the eyes. In case the patient has a red eye with the hazy cornea, mid-dilated pupil, please suspect angle closure and refer the patients to us immediately, because unlike open angle, which takes a long time for damage to occur, closed angle glaucomas, because of the acute spikes of 50 millimeters or 60 millimeters of mercury pressures that happen in the eye, the damage to occur, it takes only 5 to 6 days or even lesser. So please refer these patients to us immediately if you are seeing them. Open angle, as we have kept discussing, very difficult to pick up. But if you have any patients who are presenting with brow aches or heaviness over the eyes, patients who are having difficulty in driving and frequent falls, in which you are not able to find any other problems, please think of glaucoma in the first setting and refer them to us for a complete glaucoma evaluation. Patients may come to you with side effects of the topical medication of the eye drops that we are giving. Some of the systemic side effects are beta blockers cause postural hypotension, bronchospasm, worsening of asthma we have seen in a lot of patients actually, and impotence. Brimonidine it's a major culprit for ocular allergy, redness and discharge. Prostaglandin analogs cause pigmentation around the eyes and hyperemia, that is congestion or redness in the eyes. Acetazolamide, oral acetazolamide, again, these patients may come to you with nausea, paresthesias, electrolyte disturbances, and renal stones. Please reassure these patients and refer them back to us if you see them on these medications and having these problems. So help us in combating glaucoma, increase awareness for glaucoma from your end. Please make glaucoma as famous it's a bad thing to say, but please make it famous so that the patient gets awareness and get themselves screened for glaucoma. Explain the importance of compliance and regular follow-up for them. Again, thanking you for this opportunity. This is my mail ID. I'm always available to answer any queries.
Hello.
Yes,
Dr.
sir.
Meena,
Please.
one question.
Sir, please.
What is the best drug to treat the glaucoma initially?
It again depends on what type of glaucoma, sir. Both prostaglandin analogs and beta blockers have
Simple glaucoma.
prostaglandin analogs first line, because it has the maximum reduction in intraocular pressure. Unless the patient has inflammation, any uveitic conditions, it is contraindicated. But otherwise, I would take it as the first line of drug for treatment, because it is a once daily dosing.
Okay.
So it is patient is very compliant with it also. Easier for the patient to understand and use.
Okay. When surgical intervention is required?
So when we find that the IOP is not controlled with our maximal medication, or when I explained all the side effects, when the patients have lots of side effects with the glaucoma medication, then we do plan surgery. And if the patient is anyways undergoing a cataract surgery at the same sitting, we do offer them a glaucoma surgery if they are already on 3 or more medications, so that they can reduce the burden of medication.
Okay. How frequently field test is required?
Again, depends upon the severity of glaucomatous damage. In an advanced glaucoma, I would say 4 to 6 monthly, and in a moderate glaucoma or early glaucoma, 6 to 8 monthly, sir. And very early glaucomas, yearly once, and if pressures are very well under control, yearly once also I advise for some patients.
How to diagnose low tension glaucoma as early as possible before damage?
That is, we have to examine the optic disc, sir. There is no other alternative. We have to examine the optic disc, and optic disc hemorrhages, which are present over the disc, they usually indicate normal tension glaucoma. So we have to do a dilated examination, do a visual field if any doubt is there, or an OCT RNFL to see whether there is any preperimetric glaucoma. Other than that, except the examination part, that is the best part for diagnosis, sir. No other go. We can't, only maybe the OCT RNFL pre-perimetric stage we will be able to diagnose.
Okay. Thank you, madam. Thank you.
Thank you, sir. Thank you.
One question to Ravikumar Reddy, sir.
Yes, yes.
Sir, what are the catarogenic chemicals?
Cataract drugs.
Drugs.
Commonest is the steroid.
Sir.
Next common is aspirin. Next is phenothiazines, chloroquine, indomethacin, amiodarone. These are the common drugs we use in cardiology, majority, and indomethacin, some of the rheumatology patients, chloroquine also in rheumatology. So these are the common drugs which causes the cataracts.
Okay. Sir, in prostate treatment, they use one drug that causes the flappy eye.
Yeah, meiosis and flappy iris. Yes.
When to stop it?
So
Drug.
generally we do stop for 3 days, 4 days. I don't believe that 3 days stoppage will not have any effect, better effect. So that's why we are nowadays we are asking not to stop. We do like that only. Only how to manage this flappy iris is the first is we'll manage with the small people. If still difficulty, the best is BX ring.
Okay.
We apply BX ring and complete the procedure.
That's it. Rohit, you can ask question.
Yes,
Rohit.
sir. My question is directed towards Dr. Meena, madam.
Yes, sir, please.
Yeah, I'm an ENT surgeon, ma'am.
Okay.
Actually, we use more of intranasal steroids.
Yes, yes.
So how often in your practice you see these patients landing up in glaucoma? Is there any effect of duration of usage? And
Sir,
do we have to
there is
screen?
a group. Okay, okay. Please continue, sir.
Yeah, do you have to screen every patient for glaucoma before starting the intranasal steroids?
Okay. We have a group of patients whom we call steroid responders, sir. All patients will not develop glaucoma. Whoever are on steroids will not develop an intraocular pressure rise. But patients who are steroid responders will definitely develop it. And we cannot predict who is a steroid responder. So I would suggest that whomever you are starting on steroids, you send them to an ophthalmologist for a IOP screening and a disc evaluation at baseline and at 1 month and 3 months at least.
Sure.
If the pressures are fine, I think you can continue the steroids, and every 6 monthly once evaluation should be sufficient following that.
Okay, thank you.
Okay.
3 types: low responders, intermediate responders, high responders. The high responders I have seen within a week. Within a week, they develop glaucoma. Say, for example, how can you say? We do regularly cataract, we do regularly LASIK procedure. For every visit, we record the pressure. The visits are 1 day, 1 week, 3 weeks, 1 month. So some of the patients will develop the glaucoma as early as 1 week also. These are called as high responders. There are intermediate responders, there are low responders, there are no responders. So that's why who is high responder, who is low responder, who is no responder, we don't know. That's why when you use a steroid orally, nasally, or eye drops every week, you have to see at least for first month. If first month no pressure, generally no pressure.
Sir, one question. Local steroids and systemic steroids, which is more lethal to develop glaucoma, sir?
In my opinion, it is local. What about Meena?
Local steroids are most predisposed, but again, in those hyper responders or those super responders that we call, even skin ointments, I have seen patients having 60, 70 pressures. So those patients who are prone to develop will develop on any form of steroids. But topical is the most common because it directly affects the eye.
Post-op, even we use for post-op cataract surgery, some patients
Yes.
will develop corneal edema. Then
Yes.
IOP also it will be
We
more.
taper it fast and switch to a lower potency steroid. Yes.
So lower potency steroids we should say. Okay. Thank you.
Okay.
Okay. Vasantha
Any
Kumar,
more questions? Yeah. Any more
Right.
questions from the audience? Please, it is a very, very wonderful session from both the speakers, and we have understood cataract and glaucoma awareness. Dr. Sudhakar is asking, any experience in neurons in children? Dr. Sudhakar is a pediatrician, madam.
Congenital glaucomas are a subset we call boophthalmos, that the childhood glaucomas in the patients the child will have a large cornea, megalocornea with redness and watering. This is the triad that will be present. So again, we do an emergency surgery for them. We call it a trap plus trap, trabeculotomy with a trabeculectomy surgery, so that we can control the pressures for them.
A child who is having photophobia, not able to tolerate the light, please refer to ophthalmologist to exclude the congenital glaucoma or developmental glaucoma.
sir, what are the other signs?
Yeah, as he said, first what I have seen is the first week, second week, third week they get the chill. My child is not able to see the light. My child is not opening the eye. There is a lot of redness. These are the complaints of the congenital glaucoma. The next stage is the eye is become large. The eye is larger in size. That is called boophthalmos after the 1 month, 2 months, like that. First thing is child is not able to open. Child is not able to see the light.
Thank you, sir. Madam.
Yes. There are no more questions.
Anyone? Okay, anyone?
Yeah.
Any doubts from anyone?
I forgot to mention Dr. Anusha, who is the main person behind this webinar to happen today. Dr. Anusha, thank you so much.
Right, madam. Thank you.
Thank you, Dr. Ravi Kumar sir, and thank you, Dr. Meena. Our co-chairman, Dr. Srirang Apkari will interact, sir. Dr. Srirang. Dr. Srirang? Okay, I think he's not available.
Might have left.
Yes?
Okay, madam, continue.
No. Dr. Srirang, is he available? No. Oh, thank you very much, sir. You have made us cataract understand in a simple language for like a layman this thing, and also glaucoma. Thank you very much. And we would like to have many more webinars from your Medivision Hospital. And I am a patient from Medivision Hospital. I was very, very comfortable. And I coming to Medivision is through Chandu, Dr. Chandu and Dr. Ramesh.
Right. Thank you, madam. Thank you. So
Thank you.
we are always happy to join again and again. There are so many other specialty people like retina, cornea, and these we can include in the next webinar.
The
Yes,
next
sir.
week we'll have corneal ulcers.
Yeah, cornea, the retina also important. Oculoplasty is there.
Oculoplasty.
And
Okay.
also refractive surgery, laser surgery.
Refractive surgery and cornea will keep one day.
Okay.
Okay, sir. Thank you, sir.
Somebody wanted surgery for refractive errors, sir.
Yeah, that's
That
called
is-
Yeah.
laser surgeries, LASIK surgery.
We'll take some time and then arrange, sir.
Right.
We'll, madam, will next month we'll try to arrange one
Yeah.
corneal ulcers and lasers.
Common problems.
Yeah. Okay.
Thank you. Thank you, sir. Thank you,
Thank
Dr. Meena. Thank you, Dr. Anusha.
Thank you, madam.
Thank you, Meena Garu.
Thank you,
Thank
Dr.
you.
Chandu, and thank you, Dr. Pullara.
Thank you, Anusha.
Right.
Okay. Thank you, sir. Good night.
Good night, sir.
Thank you, madam.
Thank you. Thank you, Chandu.